for 1 or 2 years, and I found that it has got many controversies, maybe more than a lot of other pediatric diseases and disorders. I just want to focus about a few concepts. We have most of our diseases have been under study for more than a century. Okay, we have complications about obstetric brachial plexus palsy, maybe dating since the last century and maybe the century before. And we have old algorithms, procedures. Most of them have been used for a very long time, and we already know their advantages and their disadvantages because they have been studying for a very long time and for a very long follow-up. However, there is always a new research, and new research suggests a change of practice. Okay, some of this practice may be completely new. Sometimes it is just maybe a rebuild of an old technique or an old concept. But however, whenever we're reading about new research, generally in orthopedics, specifically diseases more than trauma, and more about in the brachial plexus palsy, most of our research is of low evidence. And the outcome measures that the researchers use to report their results sometimes may be misleading, so we have to take it with caution. And we also have we all know that papers take time to appear in books, okay? And some papers are more likely than others, okay? You may find in the literature that something that's more better and giving us better results, however, it was not lucky enough to appear in books early. Something like the Concept technique, which took maybe 50 years or so to appear in books. And also to be sure that many of the procedures we do and read in books are a little bit different from the way they were originally described. Okay, there are many modifications. Okay, and maybe every new book, every new book on operative procedures sometimes make the modifications, and sometimes the outcome is a little bit different from what the original surgeon devised. At least I found that in brachial plexus palsy more than any other disease, we have no two similar cases. Cases are very different because the affection varies regarding the root, the degree of affection, the degree of reinnervation. So no two cases are similar. We cannot say that we have just rules to say that for this case, for this category of cases, we will do 1, 2, 3. It is very difficult to say so. So in brachial plexus palsy, more than any other disease, I think that the a la carte approach is very important, not just intraoperative but also from the preoperative assessment. We have the brachial plexus. Upper brachial plexus affection, C5, C6 is the most common, then the total plexus involvement, and then the lower plexus involvement. Okay, we all know that the main problem following brachial plexus palsy that we all deal with is the internal rotation contraction. Okay, but we have also to put in mind that it's not only the external rotators which are affected. Occasionally, even the internal rotators are also weak, because all of them take from the C5, C6 roots. So it depends on the pattern of affection of the roots and where is the avulsion or where is the damage that happened, that we can also have, even in internal rotation contraction, we can have an internal rotation weakness. Well, this is the current outline of management. Quickly, we have a newborn, okay, who doesn't move his upper limb, we'll do a plain X-ray. If you find a fracture, then we'll embolize it and re-examine. Okay, maybe it is a fracture within Erb's palsy, maybe it is a fracture only. And anyway, if the child still doesn't move and there is no fracture, then we will initially diagnose him with an Erb's palsy. We'll put him on regular home physiotherapy, and then the current standard is when after 3 to 6 months if no improvement, then we'll do an exploration. If he's regaining the biceps function, then we can proceed with the conservative management. What we're having new here is that the buttocks is coming in Erb's palsy, and many centers abroad are using buttocks injection very early in the disease with the physiotherapy during the period of reinnervation. Okay. What we have also new is that maybe it is not too new, but it was not present previously that at 3 to 6 months if no improvement, then we have to do an exploration of the brachial plexus. Regarding the neglected or residual deformity, whether it is a case that was managed with brachial plexus surgery, but still it has got weakness and deformities, or a case that was improved and led for natural reinnervation, we are in many cases we face that we have a loss of passive or active range of motion. Sometimes this is associated with a joint deformity, sometimes it is not. Okay. And if it is not associated with a joint deformity, where the classic soft tissue releases, the subscapularis pectoralis major release, alone, isolated combination, we have got many varieties. The muscle transfers, well, we have many new muscle transfers, and many people are devising new surgeries and new procedures all the time, which means that we don't have a procedure that we can say that it provides us with the best results, okay? Well, what if we have a joint deformity? The traditional is to do a humeral osteotomy, okay? But now we're saying, well, what is the joint deformity for which we need to do really a humeral osteotomy? Some people are saying, no, we can do a joint procedures like an arthroscopic release or an open capsularity, even if we are having a joint deformity, okay? And, well, in the early papers, we used to do casting and braces for children to maintain the external rotation position. And, well, it has dropped and not mentioned in textbooks for some time, but now it's appearing again in the last editions. And they're saying, you know, if we are having a developing internal rotation contracture, in cases that are below 6 months, they again do braces and they do casting. So the concepts are changing, and sometimes things are coming. Open capsularity is an old concept coming again. Casting and conservative management was an old concept but coming back again. I picked just an old algorithm, because I believe that some of the old papers, well, have been looking at the disease maybe more better than just new papers or new books enumerating all the options that are mentioned in the literature. We said that the findings are very variable because they depend on the routes affected and the extent of the involvement. He says that if we have a minimal injury that will respond to conservative therapy, then we'll continue on conservative therapy. However, in the past, at that time, he said that recovery may require 18 months and there was no brachial plexus exploration, which is present now. Well, if we have a severe injury, the shoulder will be flexed, internally rotated, maybe slightly abducted. We have a weak shoulder abduction, and external rotation will disappear gradually due to the internal rotation contracture. And then we will progress to a humeral head loss of sphericity and maybe subluxation and dislocation. The scapula also is deformed. It is rotated and elevated. The coracoid is elongated. We have many other deformities. Well, much of this is still valid. We have to remember that the subscapularis is also a C5-C6, so it may be O2 affected. We have not just to concentrate on the shoulder, we have to look at the elbow and hand deformities. And he says, well, what we still find today that results look good when the patient is severely affected, when motion is extremely limited. In this case, when surgery will truly bring us a good result. However, in patients who are mildly affected, we have to assess them and evaluate them very carefully, because it's very likely that we will not really make a significant improvement. You can see just what is new, okay? Here he said that some believe when the only slight muscle power develops by 3 months, then plexus exploration is indicated. Well, now we don't say some believe. Now this is the standard. At that time he said only neurolysis is effective, and now this is changing. So the practice is changing, and this is just not an idea, but it became a standard. We have the brachial plexus exploration. Well, in the early days, they said that we continue conservative till maybe the age of 4, unless there is a shoulder subluxation, dislocation. But now this age recommendation is changing, and now surgery is performed maybe even under 1 year of age. Regarding the soft tissue surgery, well, in the maybe old books editions, maybe up to 2005 or even sometimes later, they all said when we have a humeral head deformity, then this is unacceptable. We cannot do a soft tissue surgery. We have to do a bony surgery. But well, this is changing now. What is acceptable humeral head deformation is now changing in the literature and is gaining more acceptance. The bony surgery, we have the oldest is the humeral derotation osteotomy, still used up till now. In the past they reported something like the glenoid posterior grafting. We have the arthrodesis, and now we have the glenoid osteotomy, but well, still not gaining much acceptance, as just mentioned in the books, but only a few people are using it now. We have, this is a controversy, anterior release. What structures to release? Maybe the oldest reported paper in most of the literature is the Fairbank paper. Fairbank released the pectoralis major, only the superior part. He released the subscapularis completely. He released the capsule completely. and when necessary, maybe he did for the coracohumeral ligament or the supraspinatus, sometimes he divided it. Well, what most books mention is the severe modification of the Fairbank. Maybe the main difference is that he left the capsule intact. He said, do not open the capsule. And this remained the standard for a very long time. Then we have the additions of the tendon transfers by microscopus and carry, using the combined anterior and posterior approach. And then we have Perrin introduced in 2006 the arthroscopic approach, which changes a lot what structures do we release, because now he is inside the joint. So what was released first was the capsule. And then the subscapularis was divided according to the degree of contraction, and he also released the coracohumeral ligaments. And again, Waters have made some modifications, and what his main impact is that he said that open capsularity is very important in cases with leading humeral dysplasia, and this has been gaining more acceptance. Well, this is the old picture of Fairbank present in some papers. Fairbank and some other authors, not only did they reduce the subluxated or dislocated joint, but they also fixed it with a wire. However, if you look carefully about the papers talking about the anterior release and whether to open the capsule or not, there is a big difference, because not all of them are talking about the same patients. We said before that maybe not two patients are the same. So it's not just enough to say that I have 40 cases of Herbert's palsy, another brachial plexus palsy, and I found that open capsularity was really bad. What are the cases actually? The cases are very different. Some cases are just contracture without dysplasia, some cases have dysplasia, some cases are subluxated or dislocated. Well, a paper that has got an impact on the literature for a very long time was the Zancudi paper of 1981. Well, because he made a group, he termed it group 1, 2. This group has got an internal rotation, abduction, contraction, with joint deformity, and posterior subluxation or dislocation. And he said that for this group, do not do a soft tissue release. You have to do an external rotation osteotomy. This paper remained a major reference for a very long time in many papers and many references. However, now this is changing. We have in many, 1990 Tactician, he said also do not open the capsule. Hoover in his different papers, he said do not open the capsule. Well, some people said different ideas, however it was not taken in the literature or in the books. Charles said, and we, 1998, and we in 2003 from Australia, said that in many cases we really need to do a capsular release. However, still the standard in the textbooks was do not open the capsule. And even some people said, actually, for those who say do not open the capsule, you really can separate the subscapularis from the capsule, because frequently we open it even if we don't want. And then came the arthroscopic approach, and they shifted the concept, because they always open the capsule. And they said, okay, you don't have to open the subscapularis, cut the subscapularis unless you really need. And you cut only until you get the range of external rotation you need. The tendon transfers, we have variable tendon transfers. The most tendon transfers which gained acceptance was the latissimus dorsi and teres major. Well, microscopic and the carry transferred it to the shaft of the humerus. Campbell in 1987, he reported that they do transfer it to the infraspinatus. And then we have the famous paper by Hoover in 1978, where he described the posterior approach to transfer the latissimus dorsi and teres major. And in addition, he didn't do an anterior release. Or if he did, he just did the pectoralis major only. And he said that this gave him good results. And actually, Hoover said that it was not his operation. It was reported by Rupert in 1971, and he just took it from him. What does this tendon transfer do? This tendon transfer increases our external rotation. Okay? Does it increase the abduction? Well, he says that the gain is in active abduction Well, due to the stabilizing effect of the rotator cuff that the transfer does. So actually we gain a better abduction indirectly. He believes that it is not the muscle transfer that gives the power for the abduction, it just stabilizes the head better within the glenoid and just enabling the deltoid to be more effective. We have also an important concept that has been reported in the literature for a very long time, okay, that in the deltoid, the anterior part is functioning better than the rest, okay, so, which is the concept in the derotation osteotomy, that when we do a derotation osteotomy, we allow the deltoid to function better. And even at that time, they try to transfer the origin of the deltoid and to naturalize it. Zinconi, I think I don't have someone else reported it before, but it is the oldest thing I found that to say that we should transfer only the latissimus dorsi and not the teres major. And then recently again we have Nat from the USA has got a lot of publications, a lot of books, okay, and he says that he transfers both of them but to the teres minor. It's not an insertion of the rotator cuff but to the muscle belly itself. Well, whatever the type of the tendon transfer, we have requisites. The shoulder should be reduced. We should have a passive range of motion. If we don't have it, then we should do an acute release. We should have a good strength of the latissimus dorsi, teres major, and the deltoid, and we should have a good hand function. And if the hand function is not good, then we should correct it better. Well, what was controversial is if we don't have a concentrically reduced shoulder. We said that the old recommendation was then you should not do a soft tissue surgery, you should do an osteotomy. But now they say that even if you do an osteotomy, you can still do a tendon transfer without a concentrically reduced shoulder. And when you don't have a concentrically reduced shoulder, you can still do an open reduction. Well, if you are going to do a tendon transfer, this is controversial. How to test the power of the muscle that we are going to transfer? There's a latissimus dorsi and teres major. We will just do a clinical assessment, make the patient make abduction, cut, or some say that the latissimus dorsi takes from the same root levels as the triceps, so we can check the triceps power if it is doing good. Okay, then this means that the latissimus dorsi will be functioning. Then others say that we should do an EMG, especially if we think that the internal rotation is weak. Well, glenohumeral dysplasia. Well, this is a rising concept since 1998, where an issue of the GBGS appeared two papers by Pirel and by Waters, which may be counted the two major references in brachial plexus palsy. The concept has been changing. Okay, they all know and reported for a very long time that we have a dysplasia in the whole shoulder girdle, and this dysplasia will proceed to subluxation and dislocation. In all publications, they said that dislocation is uncommon. However, this concept is changing. With the advent of the CT and the MRI and being done frequently to assess the dysplasia, they found that many cases actually had a subluxation or dislocation, and they were missed. Okay, because the axial radiographs in many cases was not adequately enough done to really show that we have a subluxation or a dislocation. The other concept that is changing, or actually changing, that if you have a dysplasia, then soft tissue procedures will fail. Well, this is changing. Zinconi said severe dysplasia means, or just he said humeral deformity, not just severe dysplasia, then we need to do a derotation osteotomy. This concept is changing. Zinconi said that whenever we have a positive Putti sign, this means that we have a joint deformity. Now this changed. Having a Putti sign means that we have a contracture, whether we have or we don't have a glenohumeral deformity. Well, glenohumeral dysplasia, how we assess it? Well, the Putti sign doesn't mean we have a dysplasia, like maybe was written in the older editions of Tactician and other books. It just means that we have a contracture, which is not necessarily associated with dysplasia. Well, two major papers which everybody can refer to was Waters in 2008 and Pearl in 2008. We can do an axial radiograph, which is difficult to do. We have the CT, and we have the MRI, and now recently many people are doing ultrasound. This is a classification of Waters and Bay. He made a quantification and made several stages according to the glenohumeral retroversion and the degree of humeral subluxation. We have the Pearl, we just made a descriptive, a more descriptive, concentric right biconcave pseudoglenoid. Well, what we can say that the current status from many papers in the literature, and now appeared in the last editions of Love and Medicine and Tactician, that muscle rebalancing procedures without capsular release, despite improvements in shoulder function, will not improve the glenohumeral deformity. Okay? So, if you don't, in cases of glenohumeral dysplasia, if you don't do a capsular release, then glenohumeral deformity will not improve, as reported in two major papers, Wolfers in 2005 and Cousin in 2010. The other concept or concept is open reduction of the glenohumeral joint is a statistically significant variable in improving the glenohumeral dysplasia. Even in the paper by Reading 2012, he did it even in cases with humeral head flattening, and he found that we had good results. Well, the concept is it's just like DDH. Okay, if we reduce the hip in the acetabular, then we will have a remodeling. So why doesn't this apply the same in cases of Erb's palsy? If we do an early reduction, okay, with a soft tissue balancing procedure, just like we do in the DDH, then we will have a remodeling. However, we must put in mind that they still did not correlate this remodeling with function. Okay, we shall say that it will improve the glenohumeral joint, there will be remodeling, but we cannot say now that it will improve the functional outcome. His paper of 2010 was a very good paper. He had got a lot of cases, and he did a very good statistical analysis. And from his statistical analysis, he found that, well, he has two variables that really affected the glenohumeral dysplasia. The open capsulotomy was number 2. Number 1 was the age. And he recommended not just to do an anterior release, but to do a simultaneous tendon transfer even at a very young age. Well, we have another controversial issue. Well, when we do the surgery, we are going to lose internal rotation. So, to what extent will this internal rotation be disabling, and how do we prevent the external rotation contraction? So must we do this in written tactician? To rebalance the shoulder must preserve some internal rotation function, or a fixed external rotation deformity may develop with subsequent inability to reach the midline. Okay? Well, Dr. Chandra talked a lot about this in many presentations. And well, the first time I had a case like this, the patient came complaining that, well, the weather is cold, and her child can't put her hands in her pockets, except with the other hand. So this was the first time for me to see it. Okay. And for her, this was a significant problem. Yes, she can elevate her hands better, she can reach her mouse better, but when the weather is cold, she cannot put it in her pocket easily. Well, the external, Dr. Chandra in paper 2012, he said that for external rotation, contracture of the shoulder, he classified it into 3 stages: inability to reach the lower back, inability to touch the abdomen with the wrist extended, and inability to reach the mouse easily. And also in a recent paper in I think 2012 also, there have been a modification of the mallet scale to add the internal rotation power, because internal rotation power. I'll show it later. Well, the problem is that we have many variables, and well, to know actually which of them that we should control to prevent the external rotation contraction is difficult. We have the subscapularis release. Will we make a partial release, a complete release, or is it plastic? Will we make a release from the origin or the insertion for the tendon transfer? Well, do we make a combined transfer of the isthmus dorsi or teres major, or just do an isolated the isthmus dorsi to keep the teres major? Very controversial, and nobody has said a solution in the literature. A solution that we can say that it is, well, to become a rule. Here in his paper said something important that I found in most of the papers. He said that, okay, we have been assessing patients post-operative, and we found that they do have a lot of internal rotation and an external rotation contraction. But in none of these patients, he had actually recorded them pre-operative to see a relationship between the power of internal rotation pre-operative related to the power of rotation post-operative. So, meaning that actually, did these patients have a problem pre-operative that was missed? Well, again, I'm out of that capacity. Regarding outcome measures, also still a controversial subject. We have many, the mallet score, the Gilbert score. We have for the muscle power, the active movement scale. We have many other scales. This is the modified Gilbert. This is the mallet. And here in this modification 2010 by Tozen, here they added the internal rotation. If he cannot touch the abdomen, can touch his wrist flexion, or can just have it palm on his belly. Well, now Piram and the Waters of the Bay, these got the most applications, and the chapter of the Takujin Autumn and Winter is a very good reference. And this is the final slide. Well, in summary, what we have now standard is not different from the past. Okay, if the infant has got an obstetric brachial plexus palsy, then if vital function is not regained by 6 months, then we should do a microsurgery. But if we regain a vital function, then we can continue on conservative management and physiotherapy. Buttocks now is gaining a foothold in this region, whether we do or we don't do a microsurgical procedure. Then, if internal rotation contracture develops, we no longer wait. We will do the surgical release, whatever the age is. Well, tender transfer at the same time or not, still controversial in the literature. Then, if we don't have a contracture, but just we have a weak active abduction, external rotation, then we also should do a tender transfer. Some people do it at the age of 3, some at the age of 4. Well, another concept that even if luminal dysplasia develops, we still can do a soft tissue surgical release. Well, derotation osteotomy is still good. Why? Because it's a good controlled operation, and you can know the outcome and range and a lot of external and internal rotation well from the start. Well, lenoplasty, you can try if you can.
شكرا دكتور احمد. فعلا